Hi, this is Tim, and I do have a confession to make. I really dislike taking care of peritonsillar abscesses. I think part of the reason is that it's not always easy to tell what's a peritonsillar cellulitis and what's a peritonsillar abscess. And while I don't like the idea of leaving pus undrained, I find it equally unpalatable to just go fishing around back here trying to find a pocket of pus, and you don't even really know if there is one. In addition, you know that the artery is back there just lurking, waiting to cause problems. And the whole thing kind of left me feeling a little bit like this about taking care of these abscesses. Then I read about a technique from the folks at Massachusetts General about using a submandibular approach to make a diagnosis and aid drainage of these abscesses. For several years, other authors have discussed using an intracavitary probe for this, but not all of us have an intracavitary probe, and logistically it always seemed a little bit tough to me to imagine taking some poor trismus-affected patient and sticking an intracavitary probe, your hands, a needle, and possibly a tongue blade of some sort in their mouth. So with the approach described by the folks at Massachusetts General, there were basically 3 steps to it. So the first step was just making a diagnosis. Is this cellulitis or is it an abscess? And this is basically how you do it. So you take a curvilinear probe. You probably could use a linear probe too, but I think you get a nice wide field of vision with the curvilinear probe, and you put it in the submandibular triangle on the affected side, and you just imagine fanning the beam up through the patient's tonsil. This angle is probably a little bit too shallow. You need to kind of come up a little bit more cephalad behind that tonsil. And this is basically what it looks like. And a little bit of a tricky thing about this is that you do have to remember that this image is inverted. The probe is down here in the submandibular space, and you are shooting the ultrasound beam cranially. So this is the palate up here. This is the back of the tongue. This is the floor of the mouth. And this is an abscess. And back here, this is the carotid artery. This is what it looks like on video. And the patient is speaking a little bit during this clip, but you can see her tongue moving here. And here is the abscess. And here is artery posteriorly. So now that you made a diagnosis, the next step is just doing a little bit of planning. And if you take a still image, you can make some measurements. So here is the abscess, and you can see up here it was measured, and it's roughly 2 by 2 centimeters. And even though I don't have a distance measurement on this image, the distance between mucosa here and the artery is 3 centimeters. So we know that if we put a needle in here, say 10 to 15 millimeters, we've still got another 15 millimeters before we reach the artery. So you have some good information there, but where is the abscess? When you look back there, you still don't really know where the pus is, but there is a way that the ultrasound can help you with that part of it too. And what you do is you can take a cotton tip swab, or in this case, a capped needle, and just press against the abscess, and you can see where it is. And right here, you can see a little bit of an artifact from this capped needle, and it's pressing right against the inferior portion of this abscess. So for planning purposes, I probably need to go a little bit more cephalad to really get right in the middle of it. So you have all the information you really need at this point. You can cut your needle sheath appropriately for the abscess and the artery. And then if you wanted to skip the ultrasound at that point, I think that would be a completely reasonable thing to do. You know where the artery is, you know where the abscess is, you know how deep it is. So you could go in with landmarks at that point, but you can also use the ultrasound for real-time guidance. And that's what we did here. So I have an assistant holding on to the probe for me, and we're identifying where this abscess is. I've got my needle sheath cut. And you can see by my headlight when I'm looking in her mouth and when I'm looking at the ultrasound screen. So the needle is going in, but initially I don't really see the needle. So I'm going to have my assistant just adjust the fan angle to see if I can pick up the needle. And now you're starting to see it right there. And about at this point, we start getting pus. And that went really smoothly, and I felt much more confident about what I was doing. So overall, just 3 steps. Take a look, see if they have an abscess. Maybe they just have a cellulitis and you can skip the whole thing. But if they do have an abscess, you can plan on where you need to go, how deep you need to go, where the artery is, and then you can either use the ultrasound for real-time guidance or not. But overall, my attitude about taking care of these patients has changed drastically. And while I used to dread them, I think they're kind of fun, and I do think this is a pretty useful technique.